Today is mostly focused on the pSCANNER project. There's also a lot of overlap with the interests that we have in iDash and other projects. So I wanted to thank everyone. Keep in mind that sitting assignment is very important. We learned that last night. Where you sit is everything. So I hope you have good company with you. And I'll start with a brief introduction of pSCANNER, and throughout the day you will see the details. So if I say anything wrong, it will be corrected as the day goes along, because we'll have our collaborators participating. And many of the slides here are from them. Instead of putting acknowledgement to a lot of people, I just put, this is a presentation of the pSCANNER team. So no conflicts to declare. Slides were collected from our participants. Member systems, we have 3 networks that contributed to form a larger network called pSCANNER. This originating networks were the VA Vinci, which you learned about yesterday, is the VA Enterprise Data Warehouse or Corporate Data Warehouse. UC Rex, which was a project initiated in 2010 and includes all the UCs that have medical centers, which is 5 of them. And then the Scanner project, which was one that we had funded by the AHRQ, and then got the name with a patient-centered focus for this phase. I will explain a little bit about pSCANNER's role, distributed analytics. We'll talk about it, and then Michael Matheny will, in the afternoon, expand on that. And then the collaboration with the patient-powered research networks. So the central coordination is done here at UCSD, and actually Michelle is the one who calls all the shots, and who needs to do what and everything. The OMOP transformation is directed by Daniela Meeker from RAND and USC. Analytics is Michael Matheny, BA in Vanderbilt, and also Mike Hogarth. Stakeholder engagement, Kathy Kim from UC Davis, and management by Michelle. We have several sites. They are all listed here, as well as their PIs. The right-hand side is the UC sites, the left-hand side, Vinci plus others. So let me tell you how this began. Vinci had its own network and has been developing that for many years now, and was already committed on transforming the data into OMOP. Scanner was the VA in San Diego, the Tennessee Valley VA, USC clinics, led by Jason Doctor and Daniela Meeker. And then we had the San Diego site, and this composed the Scanner network. We also had the UC Rex, which was our initiative. So at the time that the PCORI RFA came, we said, why don't we connect some dots here and get a much larger network than what we could have independently? So that's what happened. UC Rex, Doug Bell will talk about it later. It is an initiative that started in San Francisco. I have some shots here from our very first meeting. And it essentially takes data from the clinical data warehouses at all the centers, puts them into harmonizes the data. The Vera Gabriel is responsible for that activity. And then a researcher can request counts at this point, and then much more in the future. So another system that we developed is the Honest Broker, and that was developed here at UCSD, in which once we want some data sets to be collected, not counts anymore, but the actual data, there needs to be a workflow and a place to securely deposit that data so it can be retrieved by the investigator. So yesterday you saw the human subjects repository that we developed in iDash, and again, this workflow was developed on top of it, so there can be a request. The type of request is displayed. The request gets distributed. Data concierge or data guardians at each site examine the request, approve it, disapprove it, retrieve the data, put that in the safe deposit box that we have, and then the investigator can retrieve it there. So again, this was developed on top of the iDash repository, and we're currently experimenting with it. So a little bit about the scanner network, which started in late 2010, funded by the Agency for Healthcare Research and Quality. It had also a lot of institutions involved, and some of them remained for pSCANNER. One of the products of that I would like you to examine is the privacy matrix and the whole examination of laws and of regulations and privacy protection for the network in general. And Kathy Kim was the one to develop that together with Devin McGraw. So I think it's a comprehensive effort, and they published this work subsequently. Security matrix, and it had, again, a lot of, I won't put all the details here, but it was based on federal standards. And in the case of California, the California Privacy and Security Advisory Board had some guidance as well. And in the case of the VA, it was primarily VA rules and NIST. So at some point, we decided to respond to the pCORNet RFA and come up with this join of UC Rex, Scanner, and Vinci. And that was a very interesting undertaking. And again, I put iDash at the bottom as the infrastructure that supports some of these activities. We are a large networks, and red dots are our subcontracts that we have. So as you can see, it's mostly on the West Coast type thing, which created some problems at the conference calls. It was very late for the folks in Nashville, for which I apologize. But we were successful, and this was very important to keep the group going. The project overview, we have data from about 21 million patients, and we have 3 cohorts that we need to develop comprehensive data for. One is the weight cohort, so for studies on obesity and weight management. Congestive heart failure, we need to accrue 10,000 patients and have complete data for them as well. And Kawasaki disease, which is our preferred rare disease, in which we need 1,000 patients. So the timeline is 18 months, started in April. So we're on a very fast track, and we believe we can do it because of the previous infrastructure and what we have developed for other projects as well. So the goals are, the engagement goals, Kathy will talk about them later. I just want to say that there is innovation in terms of how she conceived of the stakeholder advisory board, and then when she and Daniela worked on the online Delphi consensus project. So this will be an electronic Delphi activity with a ton of members, 360 members voting on priorities and other things. So this is an experiment that we are very, very interested in, see how it will develop. And it seems simple to do, but imagine recruiting those people and the IRBs to get everything together. So that has been an ongoing activity for us. So we have to recruit and survey cohorts. So there's the survey part of, a whole lot of people to go about. Transform data into a common data model, which we selected OMOP because of our prior experience and also because of what we felt was one of the most complete standards and adequate for comparative effectiveness research. And then we will do a transformation from OMOP into pCORNet model. So it's a model that PCORI developed for this particular project. And this is being done in collaboration with other clinical data research networks that also use OMOP. So it's not a one-off thing. New York uses OMOP, PedsNet, and a couple of other sites. So we means Daniela is working with them on this particular aspect. And the VA is doing its OMOP transformation and is ongoing. We want to allow pSCANNER users to query data and build models without patient-level data leaving the institutions. So query distribution via PubMedNet and statistical analysis tools. So this is a diagram that shows how many patients are potentially available. They are in the electronic health record. We have them in clinical data warehouses, and how we will do a pCentral scanner that distributes queries and get the results from all of these places. So no data are being moved around. No patient level data is being moved around. And it's just answers to queries. So we are developing this infrastructure right now. We had pre-existing scanner infrastructure to do queries and actually do more than count queries, do some distributed computing that I would briefly comment about. So we, when other sites say, what does it take to become a pSCANNER member? Well, we have committed on OMOP data transformation. We have committed on the implementation of a pSCANNER node at each site that would then issue the queries internally. This pSCANNER node has to have access to the variables for the 3 cohorts that we're interested in, the ones that I just told you about. And then we need also to assist in the recruitment of participants for PCORI-specified patient surveys and provide members to advisory board and stakeholder panel. So I have here the pSCANNER working groups, and in red the people who are the named and the respond for that group towards the central management. We have just 4 subgroups. We thought that size was manageable to us. And we developed the governance structure so that each of the pre-existing networks would have 1 vote. Conveniently, we have 3 of them, and then we can resolve issues that way. Not many things do need to go to vote, since we all agreed on what we needed to do up front. As new demands or new findings come up, we do think there will be some back and forth and some voting around those. I won't go through all the details, but this is called EHR phenotyping, and it is from the EHR, you're building this cohort that you then keep readily available for consultations, not only of pSCANNER members, but also of the National PCORNet program, which is 11 of such networks. We are 1 of 11. And there's also patient networks, patient-powered networks. So these are primarily the organizations that do collect data directly from the patients, formerly called patient-reported outcomes, is any patient-derived data. So the combination of these 2 things will be very important, because the health systems have the electronic health record, but they don't have the details. Is this treatment, is the side effects are so intense that the patient stopped taking the medication and other things. These are all very important when you're doing comparative effectiveness. Because if you don't know if that medication is not being taken, you will count towards one side where it should be the other one. So the combination, I think, is the very innovative part of PCORNet, and something we're very interested in participating on that. So the congestive heart failure cohort has some interesting requirements, and one of them that we've been very involved with is how we will determine the ejection fraction, and many times it is still in narrative text in reports. It's very important portion for us, medications and device information and so on. The Kawasaki disease, you learned everything there is to learn from Jane yesterday. And we are very fortunate to have Jane as the Kawasaki Research Center. That is not only having national cases, but international. We need to accrue 1,000 of those cases and have the clinical data elements come from there. Kawasaki is not always expressed in the ICD-9 code, which, by the way, has a name that is hard to connect to Kawasaki disease. But if you type Kawasaki, you don't find it. It's another code. So we're trying to see how we get the largest number of cases this way. A federated query system, I put query in quotes because it's not going to be just one question. Sometimes there's a whole analysis to be done. That's not a query technically, but I'll let them go by with this just in order to facilitate. Sometimes you want to distribute a whole analytical, the construction of a model, testing of a model across the sites. And that's a very interesting thing that brings the technology we'll talk about. So we, in Scanner before, innovated by doing the distributed analytics. We have shown that many models, such as regression, such as logistic regression, and then more recently Cox proportional hazards, you don't need to have the data to compute the whole model. You can send requests, get covariance matrices, coefficients matrices back, and then construct the model out of that. And that's very interesting because you don't move data around, and people are, in general, more comfortable with it. And that's why we believe it's one of the reasons the VA is so intent on sticking with this model, which we agree with. As you heard before, they have their own enclave with the data and everything. So beyond counts, it's the questions of what are the major and minor bleeding rates for patients on these two particular drugs, for example. So this is one example. Can we predict the chance of complications? So we've been developing technology for this within Scanner that we're now passing on for pSCANNER. So the idea is, again, like I said, you don't move data around, the data stay behind their firewalls, and you aggregate intermediary results, and you can do this computation even when it's iterative. So that was another challenge that our folks had to overcome, and it was very interesting techniques. As I said, we collaborate with patient-powered networks, and Duchenne Connect is one of them. We'll have that presentation later in the day. Community Engaged Network for All is from the Genetic Alliance, and it had partners at UC Davis and UCSF, and we are also collaborating with them. Health eHeart, it partners at UC San Francisco, and the Sleep Apnea Network that has partners at the VA. So all of them, as I mentioned before, they bring the very important component of the patient-reported outcomes, the patient-derived measures. We bring the healthcare data to them. So our initial activity, and that was, Cleo has worked very hard on the IRBs for that, is that we plan to start making the patients with these conditions, with the targeted conditions, aware of the existence of this PPRNs so that they can potentially enroll to that PPRN. And between the PPRN and the CDRN, we would be able to exchange electronic health record data as well as patient-derived measures. So it would be a win-win, and we're going baby steps. The first step is getting our patients aware of the PPRNs and encouraging them to enroll. We are also working with the other clinical data research networks, particularly those working with OMOP. We also have a lot of interest in those working with the I2B2 model because the UCs have that model as well. So there's a lot of interesting synergies that we want to be able to put. Here's a plug for it's the best journal that I know in medical informatics. And I put it here because I wanted to comment on one commentary from yesterday about open access. And after I did my own commentary, the agencies should request that investigators make their articles open access. One thought came to my mind, because we did have another article that was not open access, is many times the articles are written after the grant ends. And at that point, you can't build the grant anymore, and you can't build another grant for the work that you did from the previous one. So you get kind of stuck. So that's another thought for the funding agencies, maybe reserve a pool for open access articles author fees that happen after the grant ends, because those are actually some of the best papers, because they have the complete picture, they're not intermediary analysis and so on. So with that, I leave here for questions. Again, it's a large team. We're very excited about this project, and I think it leveraged a whole lot of pre-existing materials, infrastructure, and so on that we plan to use here. I don't know who's timing, since it's not me. So what we should do, I think, in the next 10 minutes is discuss any questions or any concerns. Perhaps the PIs of the sites could just let the others know who they are. So for UC Rex, we have Latisse is not here. So she is the so Latisse right there is the program manager. Yeah, just wanted people to know. Did you have a haircut from yesterday? All right. So Latisse is our coordinator, program manager for UC Rex. The PI for UC San Francisco is Mary Woolley. Mary's right here. The PI for UC Irvine is Pietro Galacetti. He's here. The PI for UCLA is Doug Bell. Here. And the PI for UC Davis is Mike Hogarth, who was here yesterday, but I don't see him here today. The PI for UCSD, it's me. Then we have the USC, University of Southern California led clinics, and this is Jason Doctor. And the Vinci program that you saw Jonathan Nebaker yesterday. Oh, Scott Duval. All right. The bow tie is missing, you know. All right. So it's, again, a large network. It's very interesting things, and it could only be possible because of pre-existing work. Daniela is our technical person. She's also on the PCORNet task force for standards and technology. And Kathy Kim is our patient engagement or stakeholder engagement representative. So again, many of these were involved in our previous scanner or UC Rex or the VA collaborations, and you hear more about them this afternoon. Michael Matheny, he's not here in the first hour. He will be here presenting on the distributed analytics. Oh, he's coming right now, I can see. So it is probably the questions you can reserve for people who really know them, the answers, because it's not me. I'm just doing the overall coordination. But I must say it has been a very interesting process, and we met every week since the RFA got issued in terms of how to respond to the RFA. And we got ups and downs, and it was a very nice teamwork put together for this. So I'm mainly the spokesperson, and you will talk to the people who are actually doing all the work for us. I just wonder if anyone has any questions, because we are sometimes so immersed in what we're doing that we don't know if we're passing the message around correctly. So if not, we have still 5 minutes. That's excellent for the next presentation. I just wanted to tell you a story on how we came about this proposal, which was about the same time here at the IDASH meeting last year. We were saying, oh, no, we can't stay for parties. We need to write this proposal, and kind of going about it. And we had previously written a proposal for the continuation of Scanner, which we creatively named Scanner 2. So that RFA came up way before. We had already written that grant, put it out there. And when we were preparing the pSCANNER grant, we said, well, There's also stakeholder engagement there. There's distributed analytics. We need to be very careful about not overlapping the materials and so on and so forth. So that was a preoccupation as we generated the RFA. And we met every Friday. It was 3 p.m. at Pacific time. So Michael and Fern were very happy about that time and in Nashville participating. So there comes the scanner 2 score, right? And I say, well, it's Friday. I never, I don't like to give bad news on Fridays. It ruins people's weekends and so on. So I say, but I have the information now. How can I tell this people? So I remember saying in the conference call, I have good news from which you can infer the bad news. So the good news, we don't need to worry about overlap at all. And then you hear this, ooh. So it was tough. It was tough, I can say, because we've been in Scanner for 3 years. We were all engaged into it. And then you said, well, I blew it or something. But then we probably worked extra hard to get this one, and we got it. Again, no overlap whatsoever. And it was a different grant and magnitude and everything, but we were very, it was the group was stuck together, and that's what I think is very interesting about it. So we do have fun times as we go about it. But I don't give bad news on Fridays. Just keep thinking about it.